Let's discuss the 5 murmurs that you can hear in systole. There are 2 that are associated with the mitral valve. So let's jump on those real quickly. Remember, we are in systole, so you will be hearing everything from the closure of the atrioventricular valves, which is our lub, to the closure of the aorticopulmonary valves, which is our dub. So S1, lub, S2, dub. This is our mitral and tricuspid, and this is our pulmonary and aortic. The first murmur we will discuss is mitral valve prolapse. The classic cause of mitral valve prolapse is just that you have way too much valve tissue, in which you have a bunch of valve tissue, this is your mitral valve leaflets, causing the valve leaflets to push up like a parachute. So you can have tenting, which would look something like this. So it'll tent when you're in systole because there's pressure pushing on the inferior aspect of these valve leaflets. I like to think about the mid-systolic click as the sound that occurs when someone deploys a parachute and the wind catches it, causing it to expand really quickly and making that noise. The end of the leaflet prolapses because there is so much redundant tissue on the valve, and you can actually have some leakage of blood from the left ventricle into the left atrium. So as you can see in this diagram, the pressure from the contracting left ventricle will push up the redundant edges of the valve. Again, let's draw that one more time to visualize it. Bunch of tissue on these valves, pressure from the left ventricle, which is greater than the left atrium, push up, causing tenting of this mitral valve leaflet, and that is the mid-systolic click, just like a parachute catching a bunch of air when you finally pull it on your skydive. In your Step 1 book, it says that the mid-systolic click is due to sudden tensing of the chordae tendineae. But I don't like to think about it like that, because for me, it is easier just to make the association that the sound of suddenly inflating a parachute makes our click. But it should also make sense that when we tent this, the chordae that are attaching to the mitral valve leaflets are tensed and cause a vibration that travels through the myocardium, and we can also hear at the beginning of this tenting. Now, what are some other things that would cause prolapse of a mitral valve leaflet? Well, any damage to the valve, like rheumatic fever, which we discussed. So how about if you have damage to the chordae that are holding the valve leaflets, preventing them from prolapsing too hard anyways? Of course. Rheumatic fever can directly damage the mitral valves, or you can have damage to the chordae that hold this mitral valve down, and then it can prolapse. Also included on here is myxomatous degeneration. What in the world is this? People say all the time. Does anyone know what it means? I don't know what it means. It's more ambiguous than when I ask my girlfriend something and she says maybe. So muxa in Greek means mucus. Now flash back to your biochemistry. We're dealing with something that has to do with glycosaminoglycans. The mitral valve leaflets and all leaflets have a bunch of glycosaminoglycans on them. Remember, glycosaminoglycans have very strong negative charges. They are very electronegative. They love retaining water because water is a polar molecule and has a very positive end. Water just cannot say no. It loves binding glycosaminoglycans. So myxomatous degeneration means that there is just way too much of these hence mucus, way too many mucopolysaccharides and glycosaminoglycans. Thus, you attract a bunch of water to that valve. So this is our mitral valve, and a bunch of mucopolysaccharides are pulling water into this valve. This appears as a thick valve due to excess mucopolysaccharides, and it is very floppy because of the excess water that it is retaining. There's also redundant tissue, which means that eventually the connective tissue of the valve becomes weak. This will create a murmur in the vicinity of that huge mass of the left ventricle, and we know that sound travels best through thick, heavy solids. So you can go ahead and assume that you will hear this best in that left fifth intercostal space, which is the mitral area. And this is where you hear the murmur of mitral valve prolapse or mitral regurgitation. Sometimes you can have mitral regurgitation associated with mitral valve prolapse. This is usually a benign process, but it can predispose you to infective endocarditis. Why? Well, if you have this myxomatous degeneration, you have these big floppy valves that are just going all over the place, up, down, and they're just banging into each other, getting shear stress from turbulent flow. And this can cause mechanical stress and eventually injury to these valves. Remember that low virulence organisms love damaged valves, and these are the Hayseck organisms, which we will cover again in the chapter. While you also have Staph aureus, which doesn't even care how that valve is, it will just go after and get it. So we established that mitral valve prolapse has a mid-systolic click. How do you think this newly prolapsed valve will perform in keeping blood from going back into that left atrium? Remember, we are in systole, so as more left ventricular contraction occurs, there will be more increase in pressure and more blood escaping across that incompetent mitral valve. And that is why the sound will increase in intensity as we go deeper into systole. How can we augment this sound? This is one of the exceptions. Test examiners love mitral valve prolapse and hypertrophic cardiomyopathy because the murmur augmentation may seem counterintuitive at first. You can increase the murmur of mitral valve prolapse by rapid squatting or hand grip. Squatting is an incredibly unique maneuver that we need to discuss quickly. When you squat, you compress the veins and arteries of your lower extremity. The overall effect is to increase the arterial resistance by directly compressing the vessels. This will be reflected as an increase in afterload. So we increase the pressure or afterload because we are increasing the pressure in the total peripheral resistance arterioles that are downstream of the aorta. So what does squatting actually do to the murmur? Well, we decrease the ability of this left ventricle to eject because we increase the pressure and afterload in the downstream circulation. This means that there will be more blood in the left ventricular chamber. So we go from a left ventricle that's this size, with the mitral valve sitting above it, to a left ventricle that is now this size. And this will allow these mitral valves that were initially not coapting very well because they were overlapping, because they have excess redundant tissue, to now being able to coapt much more easily. This means that the click will occur later in systole because that valve will be holding out much longer due to the increased volume of blood in the left ventricle, helping the structure of the mitral valve by stretching it at its roots and tensing it up. Wait a second, my Step 1 book says that squatting increases the mitral valve prolapse murmur intensity. Well, that is also true. Over time, when the prolapse becomes severe, the left ventricle will prefer to pump backwards into the left atrium because when you squat, you increase that afterload. So it's going to take the path of least resistance. So these are two situations that you need to consider differently. How about decreasing the mitral valve prolapse murmur? Well, if you ask someone to bear down like they're trying to expire against a closed airway, or they're trying to have a bowel movement, you're making him or her Valsalva. It says in your book that phase 2 of Valsalva. Now let's talk about the first phase before we even discuss the second phase. So in the first phase, you actually increase intrathoracic pressure because you're bearing down against a closed glottis or closed airway. But when you release and take a breath, there is a pressure release that allows the aorta and the pulmonary vessels to re-expand. This is the second phase. This second phase allows the left ventricle to pump more blood into the aorta, and therefore less blood will flow backward over the prolapsed mitral valve. Okay, let's move on to mitral regurgitation, which is grouped with tricuspid regurgitation. How can we start having mitral regurgitation to begin with? We just talked about how you can get some regurgitation in mitral valve prolapse if the valve leaflets prolapse enough. So that's one way. Another way is to have an infarction of one of the papillary muscles that is responsible for tensing the chordae that hold the valve shut during systole. So if you have one of your papillary muscles that's supposed to contract down and is holding the inferior aspect of that mitral valve, if you lose this papillary muscle, nothing will be able to hold this mitral valve down. So when you're pushing blood up against the inferior aspect of it when it's supposed to be closed, it will just fly open, and then you get regurgitant blood. Which papillary muscle do you think is more likely to infarct? How about the one that usually only has one blood supply? Which do you think usually has only one blood supply? Usually this poor little fellow is the posterior papillary muscle. It usually only gets its blood supply from one artery, and that would be the right coronary artery. So this is super high yield. Repeat aloud with me. New onset mitral regurgitation is usually due to rupture of the postero or posterior medial papillary muscle due to infarction from coronary artery disease of the right coronary artery. So as soon as the pressure in the left ventricle becomes greater than the pressure in the left atrium, same thing goes for tricuspid valve regurgitation of the right atrium and the right ventricle. You will have blood moving in a retrograde fashion. We'll visualize it over here. Let's visualize it again with the tricuspid regurgitation. We have our right atrium and our right ventricle. We have our tricuspid valve. As soon as we have any sort of increase in pressure in the right ventricle, where the pressure in the right ventricle exceeds the right atrial pressure, you can have regurgitant flow across the tricuspid valve. This is just due to pressure gradients. The low pressure route always wins. Fluids do not discriminate. If I told you you had to push blood all day against the big high pressure aorta or the puny low pressure left atrium, which route do you think you would take if you were the left ventricle? I'm not sure about you guys, but I'm taking the easy way out here. The pressure in the ventricles becomes greater than the atria so fast that you cannot distinguish any sort of time gap between hearing S1 and the murmur. So as you can hear, both the mitral and tricuspid murmurs are holosystolic murmurs that occur the entire duration of systole. As soon as that pressure in the left ventricle is great enough to cause flow into the left atrium, you will have that regurgitant murmur in both the mitral and tricuspid. You will just hear them in different regions. The murmurs sound very similar. The mitral regurgitation will occur in the fifth intercostal space in the mitral area, while the tricuspid regurgitation will be best heard in the fifth intercostal space near the sternum, which is more actually close to the pulmonic valve. Again, most murmurs associated with the left ventricle and the mitral valve will best be heard where sound travels the fastest, and that is through the greatest mass of the left ventricle at the cardiac apex, which is around the mitral valve area in your diagram. Now what about the radiating to the axilla part? Remember how I told you to think about blood flow as a vector. Which way is blood flowing here? Well, we have the left ventricle separating itself from the left atrium with the mitral valve. Blood is regurgitating this way, which has a similar trajectory if you think about where the mitral valve is sitting in the heart, and that is up and towards the axilla. And that is why this murmur radiates into the axilla, because this is how the blood is regurgitating directionally. Now let's jump to the tricuspid. Where do you think you can hear this murmur best? How about immediately to the left of the sternum in the fifth intercostal space? Why? The actual location of the tricuspid valve is dead under the sternum around rib 5. So rib 1, 2, 3, 4, 5. So the tricuspid valve actually sits right here, and the regurgitation of blood in this direction will give you that murmur. When we discussed anatomy, what chamber is the most anterior or closest to the chest wall? None other than the right ventricle. Your murmur will be transmitted best through the myocardial wall of the right ventricle that is most anterior to the chest surface. Just like with mitral regurgitation, the regurgitant flow vector is in the direction of the right ventricle across the tricuspid to the right atrium. Where is the vector pointing? The right side of the sternum. This is where you can hear it radiate to. How can we make the murmur associated with the tricuspid valve louder? Remember, anything that increases blood return to the right side of the heart, such as inspiration, will increase these murmurs of the right side of the heart, because we have increased blood flowing over those structures. Same thing would be for causing an increased venous return, by causing increased venous pressure by something like vasoconstriction. What are some diseases or pathologies that can cause tricuspid regurgitation? Rheumatic fever could technically target any of the heart valves because it is an autoimmune cross-reaction against glycosaminoglycans that are components of all heart valves. Even though it is classically associated with the mitral valve, it can affect any heart valve. That's a very important high-yield subject. Infective endocarditis usually causes damage to the tricuspid valve in IV drug users. Why? Well, either they don't clean the injection site with a little alcohol swab, so even if they are using a clean needle, the penetration through the skin of the needle takes bacteria that are sitting on the skin surface down into the bloodstream. So those commensal organisms existing on our skin at all times will be taken down and introduced into the blood. And the first valve that organisms travel and meet in venous blood is what? The tricuspid. Don't try IV drugs. It will mess up your tricuspid valve. Just because it is the most common does not mean that you cannot have other valves involved. Alright, so now we have aortic stenosis. Aortic stenosis is classically described as a crescendo-decrescendo murmur. Now what does that mean? The murmur intensity will have a peak. The crescendo part is due to the continued increase in left ventricular pressure as flow is increasing across the aortic valve until you hit maximum contractility. So initially we're increasing and then we hit our max peak. As the ventricle hits max contractility and and starts to relax, the murmur will decrease in intensity because there will be a decrease in the flow, and that corresponds to our decrescendo. The murmur is loudest at the heart base because, again, a large majority of the mass of the left ventricle sits here. But since we are ejecting into the aorta, the turbulent flow can be heard all the way into the carotids. The murmur is loudest where? It's not at the heart base, even though a large majority of the mass of the left ventricle sits there. We are ejecting into the aorta. The turbulent flow can be heard all the way into the carotids. So the actual aortic stenotic murmur is where we have ejection and a vector flow towards the right second intercostal space. A term that might show up on your exam that is classically associated with aortic stenosis is pulsus parvus et tardus. For all you Latin speakers out there, you should love this, because the name tells you what exactly we're talking about. Pulsus is pulse, parvus means weak, and tardus means late. So weak and late pulse. Why is it called this? Well, if you visualize our ascending aorta and a stenotic aortic valve, our left ventricle will have to push very hard for a little bit longer than we want to finally snap that valve open. The stenotic valve is limiting the initial ejection of blood that is responsible for the large jump in systolic pressure. This means that the initial systolic pulse pressure is weak. The stenotic valve will eventually open when the left ventricular pressure raises enough to snap it open. The amount of blood ejected will all of a sudden be much higher than previous because you finally opened that stenotic valve. And this is your late peak pulse pressure after your initial pulse pressure was weak. How does the left ventricle feel about this increased pressure that it has to pump against because of a stenotic aortic valve? It's super sad because it can't open that aortic valve effectively to eject enough blood, causing a decrease in our stroke volume. Now, why is this a problem? 2 reasons. Number 1, we will not have enough blood volume in the aorta to create a sufficiently high enough diastolic pressure for adequate coronary artery perfusion. Remember, coronary artery openings are right here above the aortic valve root, and the left ventricle will eventually hypertrophy to compensate for the increased afterload due to the stenotic valve. In the case of the first situation, we will not have enough blood volume in the aorta to create a sufficiently high enough diastolic pressure. This is because we have a decrease in the total ejection of blood into the aorta. There will be less blood in the aorta at the end of systole and onset of diastole. Recall back to when we discussed how coronary arteries are perfused. They rely on the pressure and time in diastole. So if we have a poor ejection fraction, there will be less blood in the aorta to create that diastolic pressure for us to perfuse our coronary arteries. The combination of this decreased overall diastolic pressure due to poor ejection and the increased oxygen demand on the heart sets us up for ischemia. Why is left ventricular hypertrophy bad? Remember, the coronary arteries are running in the epicardium, and they send perforators through the myocardium to finally reach the subendocardial layer. The endocardium receives its nutrition and oxygenation from the blood that is in the chamber, so we don't even worry about this. The subendocardium is usually always where you have trouble because it is the farthest away from the coronary arteries that originate all the way out in the pericardium. Do you think that the coronary artery will increase in length or size to compensate for the increased thickness of the myocardial wall? So the epicardium will be pushed farther away from the subendocardium because we add mass, and these perforators have trouble compensating. There would be more muscle to crimp down on these vessels during systole, which means that we really have some very intense oxygen requirements that have to be met by perfusion during diastole. So these vessels will not increase in size to compensate. The end result is that the last layer to be perfused by the coronary artery perforators, the subendocardium, which again is directly the layer under the endocardium going out towards the pericardium. So if we are thickening the muscle around the vessels that are staying the same size, guess what happens when this poor fellow with the calcified or bicuspid valve with aortic stenosis hops on the elliptical because his wife says he needs to get in better shape? The increased workload on the myocardium will not be efficiently matched by the blood flow and oxygen delivery. He will develop some angina because the extra muscle will compress his coronary arteries when his subendocardium is already struggling to get adequate perfusion because he isn't getting enough blood into his aorta, and therefore coronary arteries for sufficient diastolic perfusion pressure. Now what about the syncope and dyspnea that you see with aortic stenosis? Well, when we exercise, catecholamines cause vasodilatation by binding to beta-2 receptors in our muscular intracapillary vascular beds. This causes a slight decrease in blood pressure. The combination of a decrease in blood pressure and limited ability to increase cardiac output for forward perfusion of the brain will set you up for a quick fainting session. The dyspnea can be attributed to the hypertrophy that the left ventricle must undergo to push against that stenotic valve. So again, we'll have concentric hypertrophy, so that means that we go from our left ventricle like this to adding sarcomeres in parallel because we need a stronger muscle, and we do that towards the center, so concentrically. Over time, this means that the left ventricle is super thick and non-compliant. When you fill it with blood, it does not take much volume for the pressure to increase exponentially. So what happens? Well, the left atrium will have to pump really hard and even harder during the second part of diastole. Remember, that's the atrial kick. So whenever you're making that left atrial work much harder, you set yourself up for atrial fibrillation and potentially the backup of blood into the pulmonary vasculature, because this increase in pressure will back up into the left atrium, and then that will go into the more compliant pulmonary vasculature. Remember what we said would happen if blood backs up into the lungs. You can get transudation of fluid into the alveoli due to the increased hydrostatic pressure in the pulmonary vessel. So this is our pulmonary vessel here. This means that you get fluid in the alveoli that are around these vessels, and that means you get decreased oxygen delivery into the alveoli. Now what does that do? Remember, whenever you have decreased oxygen in the alveoli, this causes pulmonary vasoconstriction because we do not want delivery of blood into areas where we can't put oxygen in it. That would be wasted perfusion. This is the cause of your dyspnea. You must always remember that the lungs are the unique organ system that actually vasoconstricts in the setting of low oxygen tension, because they want to redirect blood flow to areas of the lung that will allow adequate oxygenation of the blood.